Assalamualaikum. Okay, Andre. I'm in now.
Good afternoon, everyone. Once again, welcome you all for another one of the interesting session. And this is one of the very famous topic and more interested as well as the most wanted topic here in Abu Dhabi. As you all know, there are a lot of guideline updates in dental coding, and guideline is updating, billing guideline is updating every year. So we used to conduct always a dental topic every year, at least one or two, so that these type of sessions will be more helpful and beneficial for our members. And regarding the speaker selection, I believe there is no need of any special introduction. Basharart, one of the famous speaker, and he is our education officer as well in AAPC Abu Dhabi. Coming to the dental, how he is very much familiar, and he is very much active in all the dental forums and dental groups where he used to clarify the doubts, and not only based on guideline, even he is the most updated. He's one of the most updated coder here in Abu Dhabi with dental coding. We can see a lot of our officers are there, a lot of our members who are actively participating in our WhatsApp group, particularly regarding dental. We can see a lot of questions that's coming up from different coders in working in different facilities. And this topic is, we believe this will help, even though if you are not a dental coder, we will be touch basing the basics and general coding guideline and also with the updates. Hope this session will be more beneficial and it will be helping all our members, and we expect this is going to be more useful during your day-to-day life as well. I believe this will make your coding easy. The video also will be available in our YouTube channel, so always you can go and visit that. I would like to welcome on behalf of all of you, Mr. Basharart. Please go ahead, and I think you have started sharing your screen. Can you please open up your mic, Basharart, so that we can check the audio quality as well?
Assalamualaikum. Good afternoon.
Alaikum salam wa rahmatullahi wa barakatuh. Yes, Basharart, we can hear you. Yeah, I can hear you. Please share your screen, Basharart.
Okay, can you see my screen?
Yes, Basharart, I can see your screen.
Okay, thank you, Mr. Sheikh, for the introduction. First of all, I would like to thank you, Mr. Sheikh and ABC, for giving me again another chance to present myself to give updates for dental coding. Okay, welcome all members. Let's see how many members we have in now. So thank you. We have almost like 361 members attending today's session. So as Mr. Sheikh told already that this is one of the very important session in the APC, and especially if you talk about the Abu Dhabi and Alain dental coding, this is the more discussed topic. And since you know that we have a lot of updates from last 2 3 years in dental coding. Before it was not that much. It was normal going on from many years since the insurance started here in Abu Dhabi. But from last 2 years, or you can say 3 years, there are a lot of updates, especially if you have the money insurance or FICA. Okay, so some of the fresher coders and some of the new coders in dental, they asked me to start with the old slides, what I did last year. So I have added the same slides in the beginning, and then I have some updates in last few slides. So if you have any question, you can ask me in end of session or even in between the session. You can raise your hand and you can ask your question. Okay, nice. Thank you, Shaq. Okay, so our topic today is we'll discuss about the dental coding guidelines. Okay, the main our focus will be on the updates for last 2 3 years. Okay, then I will be including some additional informations and some basic knowledge about dental coding for the freshers. Okay, myself Basharart Ali. Okay, I'm CPC CCS and also I did the AI coding also. So today our topic in our just one second. Is it okay now? Okay, so content is almost same what I did last 2 years. So the last is dental updates. So we will discuss about some basic knowledge about dental coding. Okay, some physiology, anatomy, and some terminology. Okay, we'll talk about dental claims, anatomy. Then since we are in Alain and Abu Dhabi, we have hard guidelines. We'll discuss about that. Okay, procedure codes. Okay, abbreviation, diagnostic coding, and some will also discuss about denials and the coverages. So dentistry, since you know that dentistry is a branch of medical where we have different specialties under dental. So if you see the top two or three, like orthodontics, prosthodontic, those are the mostly used. If you talk about the dental coding, you will have mostly like GP dentistry or orthodontic or prosthodontic. Then of course in the hospital we have the maxillofacial and the other specialty also, not that much, but still we have other pediatric dentistry, okay, preventive endodontics, periodontics, oral pathology, and then forensic dentistry and oral medicine also. So elements, what are the elements we need in the claims? Are the diagnosis, then the dental procedures, tooth numbers. So tooth numbers now mostly they are using the universal tooth numbering, but still some of the facilities they use the FDI tooth numbering. And then some of the claims they need the authorization details. Okay, so here in Abu Dhabi, we are using Canadian dental coding. Okay, that's called the book name is Dental USC and LS. Okay, that is Canadian dental coding. So actually, this book was established in I think 2008 or 12. Since that time, it is same. There is no changes in that book. Okay, so there is no updates since that time. Okay, so that book is same. Actually, there is no changes in that book, but since we are using here, if we are talking about the audits, we are writing 20. I think 2018 version, but it is still same what they established on the first day. Okay, then we have the tooth numbering again. Mostly they are using the universal tooth numbering. So if you talk about the claim methodology, so type of encounters are outpatient. Okay, and under that one we have the diagnostic dental treatment. That is when we are billing about dental examination. Then preventive and restorative. The mostly used are this is the second encounter type. Then routine periodontics, prosthodontic, that is fixed and removable, orthodontic and cosmetic dentistry. And then if you talk about the daycare surgery, we are having the like paradigm course. Okay, so dental anesthesia. Not all the dental cases are having like a doctor is doing the anesthesia, but only like sometimes if the patient is like uncooperative or patient really needs and the treatment is painful, that time doctor gives the anesthesia. Okay, so especially so it depends if it is general anesthesia or it is the local only. Okay, so if it is a GA case, okay, especially for the uncooperative childs or special need patients, that time that they bring the patient, doctor bring the patient to the GA and then they're giving the general anesthesia. So this is the same what I discussed now. So if the like the patient is physically or intellectual or medical compromised, that time they're giving the GA. Okay, or if the patient is fearful, especially when we talk about the kids, they are uncooperative, or they have fear of that pain in the treatment, so they cannot of course sit on the dental chair. So that time they give the anesthesia. So this is a type of anesthesia: general anesthesia, deep sedation with IV or mild, moderate, or nitrous oxide. So these are the codes. Actually, these codes you cannot build in the in the clinic setting. Only when you have the like day case or inpatient, only that time these codes you can build. Okay, this is for the as I told you, like I will start with some slides for anatomy and physiology for dental dentistry. So this is for the freshers especially. So if you talk about dental coding, you have to have the basic knowledge for dental anatomy and dental terminology. If you see the tooth structure here, we have the starting from root up to the dentine. Okay, so if you see here in this picture, okay, we have this is picture of the molars or premolars. If you talk about molar, we have the surface of the or depth of when we are coding. So why this is important to know, because if you talk about the dental diagnostic code and the procedures, and when the doctor do the documentation for this, that time only you can assign the code. Just hold on, please. You can hear me? Okay, so I was talking about this the anatomy of dental tooth. So why it is important for us to know the tooth anatomy and the terminology, because if you talk about the dental diagnostic and procedure codes, most of codes only you can assign the physiology of the teeth. If you see this picture now, so we have the tooth surfaces, enamel, dentine. Okay, if you see this one, this is the pulp and the root. So we have the like mostly used codes are dental caries code. All the dental clinics, if you talk about the number of patients they are having, the largest number of the patients seen is due to caries. Okay, so when the doctor is documenting that patient has caries to enamel, okay, so he's talking about this layer, the outermost layer. Okay, and if you talk about the diagnostic coding, we have a different code for caries to enamel. Okay, So then we have the like surfaces, if it is in the smooth surface or if it is in the pit and fissure. Okay, so again we have different codes. So that's why you have to know what is pit and fissure or what is the smooth surface. Okay, so according to doctor's documentation, he will document that patient, for example, patient have caries into enamel into smooth surface. Okay, so it means he's talking about this surface. So according to that, you will assign the code. Okay, so as I told you, like we have, for example, 3 or 4 codes, or I think we have more than like 10 codes for the dental caries. So enamel, dentine, pulp, okay, then root. So this is all structure about the codes. That's why you have to know about the anatomy of teeth. Okay, then also you have to know, like, tooths are like classified in the different, like if you see here, we have incisors, we have molars, premolars. Okay, we have the canines. Okay, so again, if you talk about dental documentation, doctor will write, for example, like this: patient have caries into incisors, or right first incisor. Okay, so from that documentation, you have to know that which tooth number doctor is talking about. So then we have the like two type of dentition. It is primary or permanent. That also you have to know, because there is different tooth number for the primary dentition and different for the permanent dentition. So again, you have to know this terminology again, because once doctor will document that, like for example, if he is doing treatment, restoration, or extraction, for example, on tooth number 1. Okay, so if you talk about 1, that will be permanent teeth. If you talk about it, tooth number A, that will be primary dentition. So you have to know that which tooth number doctor is talking about. Okay, so let's talk about like primary dentition. Okay, so normally there are 20 primary teeth, 10 on each arch. Okay, so 4 incisors, 2 central incisors, and 2 lateral incisors, 2 canines, and 4 molars. Okay, so this is like primary dentition. Now we talk about the permanent dentition. We are having 32 teeth. Yep, some patient has rare cases with some patient are having like additional teeth. Okay, so that is different case, but normally patient are having 32 teeth, adult teeth. Okay, so the first permanent teeth appear around the age of 6. Okay, so when the permanent teeth start falling down, the patient is then you are having like first molar will appear on almost age of 6. Okay, so that is actually called the mixed dentition. When you have the primary teeth, the kids they are having the primary plus the permanent teeth, that is called mixed dentition. So again, why we have to know this terminology, mixed dentition? Because if doctor is doing the examination on mixed dentition, we have different examination code for primary, okay, and different for the permanent, and different code for the mixed dentition. So this term also you have to know that this is primary dentition examination, permanent, or the mixed dentition. Okay, so let's talk about the codes and the version we're using here in Abu Dhabi. Okay, so ICD version we're using is 2021. Okay, dental UCS 2011, and tooth number using here is universal tooth numbering. Okay, so same like in if you talk about medical coding, we have set of codes. Okay, here in dental also we have sets of codes. Okay, so like they are categorized into the numbering. If you talk about a 01000 to 09000 series, that is diagnosis coding. Okay, and 10,000 to 19,000 prevention. Okay, this is all about scaling, polishing, microabrasion, all those things. Then the mostly used codes are in the 20,000 to 29,000 series, restorative codes. So this all of dental coders, you're familiar that for example, you have the 1, 2, 3, 4, 5 surface restoration. We are using most of these codes. Okay, then 30 to 39,000 is endodontist, where we are coding about the RCT, pulpectomy, pulpotomy. Okay, all endodontic treatment. Then we are talking about the periodontics. Okay, 40 to 49,000. So here when we code about, like surgical retard, gingivectomy, frenectomy, those things, so those codes are lying under this category. So now the coders who are doing the prosthodontic, they are much familiar with these codes, 50,000 to 59 and 60 to 69,000. So if we talk about the revenue maker codes, these are the most like expensive codes, okay? Because and also this one actually, when we talk about the implants. So 50 to 79,000, like the mostly code used for the prosthodontics, okay, where there is like implants, bridge, okay, crowns, those things are all lying under these procedures. Yes, then again the orthodontics, all your braces and all your this appliances are under this 80 to 89,000. Then very rare we use these codes 90 to 99,000. Okay, so in dental we have like different kinds of codes. Some codes are like time-based codes. Okay, so any code description ending with where it is like a time, for example, you have scaling polishing 1 unit of time, 2 unit of time, 3 unit. So any code where the description shows that this unit of time, it means the doctor needs to document the time, start and end time for that procedure. Examples are, for example, scaling, polishing. So doctor has to document scaling and polishing. So when you see code ending with the L, some codes, like in the description is L. L mean like there is a laboratory charges in that. Okay. Then E is extra expenses. So this I was talking about the tooth number you have to know when you are billing for dental, when you're doing the dental coding. So if you see on the left side, okay, this is permanent dentition starting from 1 to 32. Okay, so these are the tooth numbering. So again, you have to be familiar with tooth numbering, because sometimes doctor will write, for example, patient has caries on upper right third molar. Okay, for example, he is documenting. So one important thing I want to tell you that if you see these pictures, okay, and if you see the X-rays, for example, these are the patient X-ray. So what we are seeing in the left side, this means this is the patient right? So if you see here, this is right. If now I'm sitting in front of the screen, so this is showing me in the left, but actually this is a patient mouth. So it means this is the right side, okay? So this is the upper right first tooth, okay? So this is how doctor, they are documenting. Sometimes they are writing that patient has, okay, caries on the upper right first tooth, okay, or upper third molar, or upper first molar. For example, he will document that patient has caries into the third molar, upper right third molar. So it means he's talking about tooth number 3. Or maybe he will write that first premolar. So it means upper right first premolar means tooth number 5. So this terminology also you have to know that when doctor is documenting, because only then you can assign the correct code. Okay, so this is the name of the teeth, and these are the numbering. Okay, so if you see talking about here, first 3 on the upper right, left, and lower right, left. If you see this one, 3 and 3, 6, 6 and this one, how many total? You have 12 molar teeth. Then premolar, 2 and 2, 4, and again here 1, 4, 8 premolars. Then we have the canines, upper and lower, total 4. Then we have the central and lateral incisors. See, central means in the middle. See this one and this one, those are the central incisors, and then in between canine and the central we have lateral incisors. So these all terminology you have to know when you are assigning dental coding, because you don't know, because doctor mostly they are documenting this one. Okay, patient has caries into first molar or premolar like this. Okay, so on the right side now we have the primary dentition. So if you see here, tooth number is from A to T. Okay, so this is same actually tooth number chart. So before, some doctors they were using the some facilities, now also they are using FDI tooth numbering, and now I don't know anyone is using palmal like tooth numbering, but mostly they're using universal. Okay, let's talk about now dental documentation. The element of dental documentation are starting from chief complaint. Okay, so again, if you're talking about dental documentation, the chief complaint also matters because some of the codes you will assign is or you on the chief complaint. Okay, for example, doctor is writing dental checkup, patient is coming for a checkup, right? So it means you will assign Z series code because Z series codes are like screening in those codes. So you will assign Z series code. And if patient is coming for suture removal, for example, you will use Z48.02. Okay, so these are some examples where like chief complaint matters. Okay, so that's why if some doctors, if they will keep that part blank, you need to query physician to add the proper chief complaint. Then the history of present illness, same like medical, here dental also we have HPI. Okay, so here doctor he will write why patient is here today. Maybe he has trauma, he has pain, he has infection, he has caries, or he came for screening or scaling, polishing, anything. So doctor will write the reason of today's visit. Then if patient has any past medical history, any trauma, anything, he will document here. Family social history. Because if you talk about the medical coding, these they like bullet points to assign the ENM. But in dental we don't have ENM codes. We have only dental examination code. So this thing are not like much matter in if you're talking about dental examination. Okay, but still he need to write if patient has any family history or social history. So the most important part in dental documentation is now the clinical examination, where doctor will write, for example, his doctor is giving, for example, 2 or 3 diagnostic code. So in this part, he need to be very specific in documentation. Like for example, as I discussed before, we have, for example, 10 to 12 codes for dental caries. The doctor cannot simply write patient has caries. He need to be more specific. He will write that patient has caries into smooth surface, into tooth number, and he will write the surfaces. Okay, then in the this clinical examination, he will write intraoral examination, extraoral examination. So intraoral is whatever he will see in the patient mouth. He has abscess or he has caries, he has accretion, gingivitis, whatever. Then extraoral, if patient has any redness and swelling, he will write here. Then hard tissue is all about the bone and the teeth. Soft tissue is about the gum or any like like he has anything in his other soft tissue area. Then radiographic findings is also one of the important in dental documentation. Whenever doctor will take any X-ray, PA X-ray, white wings, OPG, he need to write the interpretation for all the radiograph taken. Sometimes doctor is taking the X-ray, but there is no abnormal finding. Even then, he will write the purpose of taking the X-ray. For example, they are taking the OPG, patient is having pain, for example, in the molar. So he will write that patient has caries or he has pain in the for example in the molar. Okay, but there is no visual caries, he cannot see. That's why he is taking the X-ray to know more about the maybe there is deep caries or there is abscess or there is something. Okay, so that's why so he need to write that interpretation for the taking X-ray. Then narrative diagnosis. So narrative diagnosis also is one of the important part if you talk about the again the audits, especially the jaw audit. They are focusing more also in this area also. So doctor need to write the narrative. So what is different between narrative and what doctor write in the internal examination? So examination is what he sees. So there should be some difference, Narrative. Narrative is narration of that what a diagnosis is saying. Okay. So there should be some difference in internal examination and narrative. Then again the important part is procedure notes. In the procedure notes, he need to write detailed procedure note. What if he's doing, for example, extraction also we have multiple codes. Simple extraction, surgical, remaining root, okay, and impacted. So a lot of codes are there. So doctor need to write everything. If it is surgical, what kind of instrument he has used, okay, he has controlled the bleeding, and what other things he has used for that procedure. Okay, all the techniques, all the instrument used, okay, all the precautions given. So he need to write everything in detail. Why this is important? Because, for example, if doctor is doing the extraction, okay, then I remember, before this audit, doctor just used to write only extraction done to number this and this. And the billing was sometimes simple, sometimes surgical, sometimes impacted teeth. So how the payer, they will know that what kind of procedure was done. And this only, they will know only if your documentation is complete. Okay. For example, you have done the remaining root, okay, RR extraction. You need to write here that patient has root, and this was the like for example depth of the root, and he removed, how he removed, simple or surgical, what kind of instrument he has used. Okay, so all these details you need to write in the procedure. And again, this is the most important, because if there is not much documentation, that will be marked as error in your audits. So make sure that you query the physician if there is not much documentation. Then the tooth numbering is also important part. On which tooth doctor has done the treatment, he need to document. Okay. Then the last thing is what kind of instructions are given to patients. Okay, after the extraction or after because some of the facilities they build the OHI. I know it's not covered in the private, but when OHI is given, it need to be written in the documentation. So some of the common used dental abbreviations are here. When like doctor talk about the upper arch, he will write okay, upper arch, lower arch, LA. Then quadrants, upper left, upper right, lower left, lower right. So these are like common you use. Most abbreviations doctor they're using is, for example, for the when they are doing the multiple restoration, so they can write, instead of writing the surface of the tooth, like for example mesial, occlusal, distal, they can just put, for example, MOD only. So that is also example of dental abbreviations. Okay, dental charting. So I see most of the clinics, they are using dental charting, not because in the audit they are asking about this one, but they are for their own good documentation. Because for example, patient has, when the first time they see the patient, maybe patient has multiple issues in his teeth. Maybe some are missing, he need implant, some are with the caries, he will do restoration, some have cracked tooth. So if you see, this is the example in this one. Okay, so if you see, this patient has multiple teeth issues. For example, there is a fractured teeth, this is abscess here. Okay, they are missing teeth. Okay, some have post and core. So this charting will help doctor. If some doctors, they are very good in charting. So instead of reading all this full document, from this chart he will know that which tooth has what issue, and what maybe some tooth are partially treated, some have crown, some have bridge. Okay, so from chart itself they will know in one picture, within it will save their time. If doctors they are having good charting, they can save their time without reading the complete documentation, previous documentation. Just imagine, if a patient has, for example, 32 teeth, and all the 32 teeth have some issue, especially if you talk about the old age patient, they are having multiple issues, right? They have the bridges, they have crowns, they have extractions, they have restorations. Okay, so it is difficult for doctors to read all previous documentation. If they have good charting, only from one picture they will know that which tooth has what problem, what appliance they have. Okay, so good charting is one of the very important thing. Okay, especially for the doctors, to help doctors to save their time. But if you're talking about the examination, whenever doctor will bill for the full mouth examination, it means they need to have this complete chart. Because again, in the audit they will ask you, if doctor is billing for full mouth examination, they will check this code also. The charting. Just 1 second, please. Okay, so that's why the charting is important, because as I told you, if you talk about the full mouth examination, that time of course the auditor will check, but for you, for your own good it is like for doctors, it is good for them to have the charting in their all files. So this is another abbreviation I was talking about. So if patient has the, for example, multiple caries, for example, facial, F, incisal, I, mesial, lingual. So instead of writing all this buccal, mesial, distal, he will put, for example, M or B. So that means mesial, buccal caries he has, and when he will do the procedure, he will just write that caries was removed and like restoration was done on M or B surface. So that will also, this abbreviation will help them. Okay, let's talk about now the dental ICD 10s. I will just move fast on these slides because since because of my main focus is about the dental updates. Okay, so these are most of dental diagnosis you will find in the K series code because dental are coming under digestive system. So all K series codes are from digestive system. Okay, so if you talk about the K series code, okay, all the codes are K02, 62, 52, all those are under K series. Okay. So these are like you see K series, this order of teeth. K01 are all impacted. K02 caries. Okay. So this is the like mostly used. Then all these K series are under the, even if you talk about the lips and the tongue also, those are under the K series code. Okay. So these are mostly used codes, ICD. So these are M series. So those are K series and these are M series. So M series are mostly you will find in the orthodontics. So the coders who are doing the dental coding, orthodontics especially, they are familiar with these codes. Okay, all the malocclusion, spacing, crowding, all these codes under M series. Then some of the codes we are having from S series also, like trauma cases in those cases. So we have the S series in that also. Like for example, dislocation of teeth, or if you have fractured teeth. Okay, so all those codes are under S series. So this slide I put here again for dental coders. Why? Because some coders they are confused with the fracture restoration or cracked tooth or the fracture tooth. So what is different between in all these? Simply, when doctor is again all about doctor's documentation. A doctor will write patient has cracked teeth. So simply you will use this code K03.81. Okay, so whenever you use a cracked pin, you will use this code. Okay, fracture, if doctor will document patient fracture teeth, you will simply write this code S025 XXA for the initial visit. Okay, and plus of course you have to use the like external cause. For example, patient is having the fall, you will use a W19, that W series code. Okay, fall or hit or something. So whenever doctor will document that patient has fractured teeth, always query him to write the reason of that trauma or that fracture. Okay, so he need to document that the patient has fall or something hit him, or maybe he eat the hard food. Okay, so you have to use this course. Right. Then about the fracture restoration. So it's clearly mentioned here restoration. It means that patient has already restoration in that fracture. So now we have here the with loss or without loss. So it means if patient had the fracture restoration and the part of sometimes like we have the fracture restoration, but the it's a classy that fell down, that the restoration. So that means with loss. So if patient have that only like crack or broken restoration, then you will use one of these code. Open margin cases. This code mostly when patient is having the crowns or any like a denture or something, then they are having open margin. So that time you can use this code. And this unsatisfactory. So this is actually unspecified code. Unsatisfactory is actually if you talk about like when patient is not satisfied, it means patient is having some kind of issue, or maybe he has a high feeling or something, or you can use this code. It means patient is not satisfied with that restoration. That time you can use this code. So this was just to clarify, because like since some code they're having some doubt about the crack and fracture tooth. If you see this code, this is very clear. It seems that it is broken tooth. Okay, so crack means if there is line. Okay, so if you are like querying doctors and doctors, because doctors they're not coders, so doctors they will just simply write crack tooth or okay, and you will just put according to that code. So better like you can tell them if this crack is there, then he will put the documentation of crack. Okay, about the procedures, already I discussed that 01,000 to 99,000 we are having dental codes. Okay, so this we discussed already. So now we will discuss one by one. So if you see this one, all the evaluation codes, all the examination codes are from 1,000 series. Okay, so all examination. So if you see, for example, full mouth examination, this one, see complete primary, complete mixed dentition, complete permanent dentition. Okay, then we have the recall, specific, okay, emergency exam. So these all are the code we are using in dental examination. But before, what was happening that, as I told you, we have now updates, a lot of updates from last 2 years. Before, in every visit, for example, patient is coming in the first visit, codes are billing 01201. Then again he's coming with a pain, we were billing 01205. Then again he was coming with some other like recall. So now we have very limited now, because since now some insurance companies, they already announced that they will pay only one exam or within 6 months. Okay, so make sure that you are billing the proper. What is the purpose of that visit? Is for full mouth examination, is limited exam. According to that, you can assign your examination code. Okay, so these are all the codes for dental examination. So make sure that if patient is coming with the pain, you will bill for emergency exam. Pain, any trauma, any like abscess, any swelling, something emergency case, you will bill for this 01205. If patient is coming for the full mouth examination, as I told you, see the primary, mixed dentition, and permanent. So make sure that this is also one of the areas where the auditors are checking. So make sure that if patient has mixed dentition, you will bill this code, mixed dentition. Okay. If it is primary, this one. If permanent, this one. Okay. So make sure you are assigning the proper examination code. And these all are like specialist examination. If you see this one, this is for the prosthodontic. Okay. These are for the surgical, endo, perio. For so each specialty, dental specialty, we have different procedure, examination procedure code. Okay. So make sure you are assigning correct one. Just one thing I want to, if you talk about this 01902, okay, so this codes 01901 is for the dental examination, which need approval. 01902 is for the orthodontics. Okay, so since they are paying only now 6 per month, so you will only bill this one. Okay, so after 6 months, okay, you will, of course, you will bill the other, like monthly visits. You cannot bill 01902. 01902 now only, especially the man. If you talk about the man, they are paying this one only if you have the second opinion. Okay, so this is the immediate exam, recall, specific, emergency. Okay, so most of cases you are having this one, like when patient coming with the pain. Okay, so emergency mean when patient has pain, abscess, fracture, severe bleeding, trauma, discomfort, sharp edges. So these kind of things all are under examination. But even if it's emergency, even then, like insurance company, they will pay you if it is more than 6 months. Okay, yes, if patient is doing examination, yes, you can pull as a zero billing, you can still bill it. So if you talk about dental examination, as I told you, why did doctor they take the x-rays? Because when patient is having any complaint, dental pain or anything else, so first thing what doctor will do, he will open patient's mouth and he will see if anything is like a visual, he will see with eyes. But most of cases, because like a dental tooth, they are under the gums, so of course with cannot observe of the pain. That's why what doctor will do, he will send the patient for the x-ray. Okay, so we have different type of x-rays in dental. Okay, P x-ray, we had bite wings, we had OPGs, like in panorama, so CBCT. So a lot of there we have the dental x-rays where doctor will ask patient to go and take the x-ray to know more about why patient have pain. So these are the like x-rays, mostly like when doctor they are they want to know more about what is the reason of pain, or for any treatment, for example, orthodontics. So they are taking this kind of X-rays. So these are bite wings, or these are OPG. Okay, tomography. This one. Okay, these are this one. Okay, so occlusal. So these are now very rare they are using on, but now mostly you're using the OPGs. Okay, CVCT for especially for the pros one, ortho, and maxillofacial cases, they are using this one, cone beam. And then mostly this is the periapical. When patient is having any RCT or any like restoration, they're using the P X-rays. So this is the update again from the some insurance companies. The P X-ray and bite wing no more billing Pratik or the month. OPG is once per year. Before it was 6 months, now they are paying only once per year. Same for the cephalo X-ray. Okay, so once per year. Okay, let's talk about now like dental procedures. So examination finish. Now about prevention. 10,000 to 19,000 all codes are under prevention. So again, mostly used codes are only few only, scaling, polishing. Those codes are mostly used in the prevention. Okay. So why they are doing, when patient is having any plaque, okay, deposits on the teeth or any gingivitis, then doctor is doing the scaling, polishing. Okay. So the supporting diagnosis mostly, like these are the one like gingivitis and accretions. So these are the codes now. Scaling, polishing, okay, but only we are not using all this code, but only few. So again, there are some updates. We will discuss that update in the upcoming slides. So this is what I was talking about. The mostly used codes in dentistry are restoration codes. Okay, so if you see this picture, actually patients have is see this one. So why I was talking about you have to know about dental terminology and anatomy. So if you see this one, the caries start from here. See decaying teeth. So if you will not care of this caries, it will go more deep into dentine. Okay. Then still, if you not take care, again it will go to pulp. Then it will make issue with your teeth, and it will affect your pulp, and even in your roots and abscess, all these things. Okay. So that's why, like, if you are patient yourself, you have to take care of your teeth. If only the caries started, same time you need to see the doctor. Okay. So your tooth will be okay then. Okay, and if you talk about coding now, so we already discussed about like that the like depth of the caries. Okay, so you will assign coding according to the depth and surface of caries. Okay, so all these codes. So these are the procedures. We have multiple procedures for dental restoration. Okay, so mostly when doctor they are doing the restoration, they are using the mostly composite material. Okay, so again, this is important for doctor to document that what kind of material he is using to do the restoration. Okay, also he need to write that again the techniques, tooth number, and the material he has used for the restoration. So again, as I mentioned, this, if you see the right side, these codes all are, see this, we have different codes, see amalgam filling, and then we have the composite. Okay, so make sure that you are using proper procedure code when you are billing for restoration. Okay, and doctor need to document very clear that what kind of instrument and the what kind of material is used, plus the tooth numbering. Same for the RCT. RCT mostly we are having like and endodontic we are using mostly the pulpectomies, RCT. Okay, these code mostly we are using it. Okay, so make sure that doctor is again documenting the complete documentation when he's like the reason why he is going to do this treatment. Is it RCT? Is it pulpectomy, pulpotomy, whatever he's doing? He need to write the reason. The reason mean that I can say like a patient has pulpitis or he has deep caries, okay, abscess, whatever he has, he will document, and according to that, you will assign your code. So we have again we have the hard education guidelines also new for the endodontics. I have the slides for that. We'll discuss more in those slides. So periodontics, here we are having mostly gingivectomies, frenectomies, those things. Actually, the periodontists, they used to do scaling, polishing, those things. But if it is more like specialist kind of work, then now again, the new scope of service, all the specialist cases you will refer, like GPs, they will refer to the specialist. Okay, so wherever there is periodontics work, the GP, they need to refer patient to the periodontics. So some of the procedures, for example, we are having the surgical curettage or gingivectomy, frenectomy. So all these codes, these cases need to be referred to periodontist. Okay, so these are like some like example of the procedures. Any period surgery, flap, okay, as like gingival fiber incision, gingivectomies, okay, curettage. So all these codes, if GP is doing, he need to refer it to the specialist. And the diagnosis we're using is here. See, mostly you're having here like gingival enlargement or periodontitis. Okay, so if you're assigning the code again for the periodontitis, we have multiple codes. So make sure again the doctor need to be more specific when he is documenting the periodontitis. If you see on the left side, we have multiple codes. We have the aggressive, okay, we have the chronic periodontitis, generalized, localized, then severity is there, the slight, moderate, severe. So make sure that doctor is more specific in his documentation. So according to that, you can assign more specific code. So in this, most of the periodontist codes, you are having per sextant or per site codes. If you see this one, for example, the gingivectomy or frenectomy, those are per sextant code. What means sextant? That's if you can say like six. Okay, if you talk about canine to canine, okay, so those are six tooth. Okay, so then left and right. Okay, so it means how many tooth we are having? Almost 16, right? So if you start from here to here, so doctor need to actually write, it is first sextant or second sextant, or like he can write site. Okay, so or even he can write tooth number also, on which tooth number he has done the procedure. Okay, so why it is important? Because for example, doctor is doing gingivectomy on, for example, from canine to canine, so he cannot bill for each tooth, right? Because this code is per sextant. If you will bill for all this is overbilling, because this code is only per sextant, so you will only assign one code for all these 6 codes. Okay, so make sure that especially for the new coders in dental, they have to know this per site codes or per sextant code. Those are not per tooth. Okay, so make sure you are assigning correct code, and doctor, he need to document exactly from which site or which sextant or which tooth number he has done the procedure. Right. Okay, so now we are coming to the orthodontic cases, removable. So what is different between fixed and removable? Okay, so simply from it word itself, removable mean, like when the like our we used to see in our like grandparents, they used to sometimes remove their like dentures and keep and wash and then put again. So which mean removable, they can remove it simply. Okay, so fixed mean fixed like implants or those things. Okay, so these are the codes for the prosthodontic removable. So these are actually the dentures, dentures. So we have many codes for denture. Again, as a coder, you have to know that which kind of, again, the material or which kind of like a thing doctor is using. Okay, if you see in the right side, these are only few codes. There are much more big list for the denture codes. Okay, see dental surgical, complex, denture complete, and partial. Lot of codes we have for denture. So make sure you are using the proper code for dentures. Okay, same for diagnosis. So if it is complete denture, it means patient has complete missing teeth, right? So you will take care code from K081 series. Okay, so what is K081? It means complete missing teeth. Okay, so again here also some coders, they are confused like with what is different between complete missing teeth and what is partial. Okay. Actually, if you talk about the code description, that's one of the reason, some coders, they are confused, that because if you see here, complete loss of teeth due to caries. So what some coder they define this code is, it means that one tooth patient remove, like patient lost one teeth, and that whole teeth is gone due to caries. Yes, you can like define this code like that, but if you talk about this the procedure and the insurance company's payment, then only you will assign these complete missing teeth when patient complete arch is missing. Okay, for if you see this, for example, now this, for example, this denture, so it means this is partial only. Why it is partial? Because patient is having teeth already in a different, okay, or on this area he has teeth and this is denture. Okay, so why they keep this area? Because patient have already the like his own natural teeth are still there in that arch. So it means patient is, you will assign core from case 8 series, partial loss of teeth. Okay, partial of this mean patient have few teeth and on his arch, and other he will put whatever, he will bridge or denture, whatever. Okay, so make sure that you are assigning the proper ICD and proper procedure code. Okay, so you have to know this terminologies in this one. So this is the codes for missing teeth. See, there are many codes. So again, here, doctor, you need to query the physician. When doctor will write only missing teeth, you will query the physician that he need to write the reason of missing teeth or cause, why the patient like losses, how patient loses teeth. Okay, maybe it is due to the disease, periodontal disease, maybe due to trauma, maybe due to caries. So if you see here, we have many codes. Okay, but what's happening? Like again, if you talk about the old age patient, they lost teeth and now they are coming for the implant and they don't know what was when they lost his teeth and what was the reason. Okay, so in that case, because most of the patients, they are visiting on the same facility, right? So that doctor knows, okay, I removed this tooth and I know this is due to caries. But if the patient don't know and you don't have documentation, then simply doctor can, he can write just patient lost the teeth, and yes, the class, of course, they will know. So better to write the class even they don't know the cause. Okay, so class again, like mostly like using the Kennedy classification of the missing teeth. So that doctor, he will know. Even like coders, if you see, go in the Kennedy website. Okay, okay, let me, I think I have in the one slide. Well, let me show you 1 second. If you sell this Kennedy missing teeth, okay, so you will have this kind of C classification. So I will share you the later on. I will share you this one I have saved. So here, so this is just for your knowledge. Actually, doctor, he's the one who will actually know this one. But for your own knowledge, okay, you have to know that this is important to know the classification. Okay, see this one. So Kennedy class 1, class 2, class 3. So this is how we have the codes here in this slide. So see, class 1, 2, 3, 4. Okay, so that's why better you need to be familiar with this classification also. If not, that's also fine. You need to like just tell your doctor. Okay, so these are the codes due to trauma, class 1, 2, 3, 4, due to periodontal disease, class 1, 2, 3, 4, and due to caries, mostly this we are using. So 1, 2, 3, 4. Then due to other specified cause, maybe patient had any other cause, maybe he's like anything else happens, so you can use. So is this one, C4, K084 mean partial, K081 mean complete. Okay, so make sure you are assigning the correct diagnostic code. About the procedures, now about the fixed, this is what I told you, like what is in between the removable and the fixed. Removable, the one they can remove anytime, and fixed are which are fixed already. Okay, fixed maybe with the screw and with the glue or this one Pontex. Okay, so if you see this one, this is example of the fixed, this bridge. Okay, so you have abutments. So what are abutments are here? The natural teeth. They will just prepare this tooth. They will this like a crown will be written on this one, and this is like now the Pontic. Okay, so it means patient has missing teeth this one only, but other two teeth they prepare and they fit on this one, and patient can like have good smile and he has good teeth here. Okay, about the procedures, you have to again know that we have again many codes for the pontics and retainers. So again, make sure that you are assigning the correct procedure code. Okay, so pontics, and sometimes you are having the multiple missing teeth, and doctor will make the bridge. Okay, so this is actually called a bridge. Okay, so this is how they are multiple tooth bridge also. Okay, so make sure that again the doctor is tracking the correct procedure, not in the you are assigning the correct procedure code. Okay, now let's talk about the coverage facts. Orthodontic treatment. So it cannot be covered as routine dental examination. It cannot be covered more than once per case per provider. Okay, so orthodontic cases you can only like like this is per provider. Okay, so it means if one doctor he has done already the billing for the braces. Okay, they already delivered the braces. So other facility they can also use this per case. Okay, so these all code need the prior authorization in the monthly visit now. Okay, it cannot be billed in the same invoice. So the coders who are doing the orthodontic coding, they are familiar that like how many days now monthly visit is 45 days, right? And you cannot assign the monthly visit and the like braces code on the same day. Okay, so make sure that you are familiar with the orthodontic coding guidelines. So some of the like codes are not covered codes. Okay, for example, cosmetic treatment are not covered. In-ears bleaching is not covered. Microabrasion recently update. Before they were paying, now microabrasion is not more covered. Okay, about the crowns also there's update now. Like from last 2 years now, GP they can bill only 3 crowns per arch per quadrant. Okay, so again some coders again they were confused about this about the crowns. So what mean by like per arch per quadrant? It means that if doctor has started already, for example, patient has like he need crown on the tooth number upper right. So if doctor has started already upper right, it means he will complete 3 crowns on upper right. He cannot touch on the left side. Same on the lower arch. If doctor has already billed for the 1 crown on the left or right arch, so he will complete or he will have 3. He can only bill 3 on same arch, same quadrant. Okay, so make sure that you are, because anytime like an insurance company or the man they can recover if you are billing on a different quadrant. The polishing also now, if you see the recent update, polishing additional unit also you can bill. Dental X-ray already discussed, like now they are not paying like P X-rays, white wings, those are no more billable. OPG and the CPCT once per year. Dental examination, I told you 6 months. Okay, so dental crowns, we have like as I told you, like we have recent updates for dental crowns now, prosthodontic and endodontic. So you have to read all like that new education guidelines. Okay, what are the updates? Make sure that you are familiar with all this, whatever they mention in that health education guideline. Just go through all this. So I will just read some points for you in this slides. Okay. So if you see the first one, root canal treated tooth do not qualify for crown. So what was happening before? That every RCT case, okay, it was like approval was sent for a crown. Okay, so now what they are saying that root canal treated teeth do not qualify for a dental crown. Okay, so it means not all the RCT treated teeth need the crown. Okay, instead, documentary evidence and clinical justification for legal need for crown on root canal treated teeth must be provided. Okay, so why that tooth need crown? Doctor need to justify in his documentation. So what kind of like justification? Of course, like he need to write that patient don't have much tooth surface, okay, or patient cannot eat with this, and so that's why he need the crown. So that it means like from the X-ray and from doctor justification only you will get the crown approval. Crown for root canal teeth should be based on through assessment, taking into consideration factors such as extent of tooth damage. See, so they will know like tooth damage, remaining tooth structure, functional requirement, and overall health status. Okay, oral health status. Okay, so these all things now they will consider. So you make sure that they are writing the all is correct. Okay. If you talk about the now about the like longevity and the age threshold, so before it was 5 years, now the longevity is 6 years. Okay, before threshold was 15 years, now 16 years. Okay, and other thing is now provisional crowns. Actually, if you actually chair side they are not paying, but provisional now you have to know that provisional crown may be reimbursed separately when it lies in an infirm restoration for at least 6 months. So what does that mean? It means when you're billing for the provisional crown and you're sending approval for the like the final crown, you cannot bill within 6 months. Okay, so it means that the provisional crown what you're delivering, okay, it need to be there within 6 months, and after 6 months, then only you can deliver the final crown. Okay. I have some more updates, but let's talk about first denials first. Okay, these are the like top 10, you can say top 10, this blue one or top 10 denials we are getting in dental. Okay, so let's talk about first authorization denials. So what are authorization denials? Auth 1 is denial when like you have built something but there is no approval number, or maybe you did not get the approval. Okay, sometimes what's happening, you submit the claim but you forget to add the approval number, so that time you will get the auth 1 denial. Or sometime maybe you didn't get actually approval, you just bill it. Why? Because some of the coders, again, they're not familiar that which code need approval, especially when you talk about the dentures and the bridge codes. Okay, though like there we have the list, that list indicates that which code need approval, which we can do direct billing. Okay, so make sure that again all the dental coders they need to have that list where it is mentioned that which code need approval and which doesn't require. Then auth 3, so when you are, since like approval number is very big, so you cannot type it. Always make sure you copy paste from your like OpenJet or whatever you have, so from the portal. Okay, just copy and paste in your claim. Okay, because if you will type, for sure you have chances to write the wrong authorization number. So if you are writing the wrong, it means you will get the auth 3 denial. Then we are having auth 5. So that means maybe you have had the 4 diagnostic code in the approval, and in your claim you submit only 3. Okay, so you will get this, or maybe you put the wrong tooth number. Maybe you send approval for tooth number 3 and here you write 4. Okay, so it means that is wrong. So you have chances to get the auth 5. Then we have auth 4. Auth 4 means expired approval. Okay, so if you see outside authorization, so it means auth 4 is expired. So make sure that like when you are billing, before you put the approval number, make sure that you double check your approval number and that is valid. Okay, and there is the it's not expired. Okay, then we talk about the medical necessity denials. Okay, MNAC 3 and 4. This mostly you're getting. So MNAC 3 is like you're getting mostly in dental when you are having the wrong tooth number. Okay, so make sure that you are adding the correct tooth number. And MNAC 4 you are getting when you are not adding the supportive diagnosis. For example, you are doing, for example, the scaling polishing, but there is no code for the deposits or accretion, gingivitis. Okay, and you will get this auth 4. Same for the restoration. If there is no caries code or like any supporting diagnosis, you will get auth 5 denials. Then about the co-pain eligibility. So this eligibility, yes, since like now all the patient they need to get eligibility, and then you can see the patient. If there is wrong card number, then also you will get this one, the eligibility one denial. So those are the most common. Other you can just go through later on. So time-based codes, again, yes, there is update for the time-based codes. Okay, so make sure that when you are having like multiple procedures built for the time-based code, make sure your time is correct. Okay, so add start and end time for each, minimum of 8 minutes per unit. Okay, but if you are billing for 2 units, for example, you are billing for 2 units for scaling, Then the first unit will be 15, additional will be 8 minutes. Okay. Again, that's I have another slide you will see in that one. When you're getting the approvals for process and orthodontic, so you need to have all these things to attach to get the approval. OPG, X-rays, photos, assessment form, and if there is any medical report, you need to attach to get the approvals. About the audits, okay, so audits are same, what I discussed already. You need to have the community documentation, all these things, okay, X-ray finding, tooth number, X-ray images, okay, so you need to have all this to prepare for the audit. Okay, and now talking about the updates, we have like last 2-3 years, okay. So if you talk about this one, frequency and coding of routine dental services. So I know all of your dental coders, they are familiar with this circular you got from the MAN. Okay, so even now some coders, they are confused with this table. Okay, so let's talk about this table, what it means. So when you can bill for scaling, see here, below 6 year annually 1. What does it mean? So if the patient age is less than 6 year, so 1 unit in 12 months. Okay, so it means only you can bill 1 unit per year, simply 1 year. Okay, annually one per year. Okay, so you can bill only one. So you cannot bill additional 1119. Okay, only you can bill only one time scaling. If it is 6 to 12 years, then you can do biannually. What mean biannually? It means every 6 months 1 unit, no more again 1119. Okay, yes, above 12 years, yes, you can bill 4 units in 12 months. Okay, so here some coders were confused that they think that 4 unit means they can bill, okay, 11119 4 times. No, it means 4 units. 4 units is this, and this is 2 units. Okay, so biannually. So see this one, biannually, to like twice per year. So simply is that same like before. Okay, so it means within 6 months you will bill this in this one. Again after 6 months you will bill this in this one. Simply. So see 2. Okay, so primary and add-on code 2 times. So simply after 6 months you can bill 2 units scaling, 2 polishing. Okay, make sure that I know even now some coders, they are like confused with this one. They keep on billing this one like after 3 months or okay. So 4 unit doesn't mean that 4 times, it means 4 units only. Okay, let's talk about now polishing. Polishing is below 12 years 1 unit in 12 years, same. So simply it means that any patient below than 12 years, you can bill 1 scaling, 1 polishing, simply per year. Now about 12 years, so see now here polishing less than okay, below 12 years. Okay, 12. Now about 12 years you can do biannually. So again, see now here you cannot find now 1109. What that mean? That for polishing 2 unit you cannot bill. So again, what it mean that, for example, patient is coming now and you will bill 111, 119 and 1101. After 6 months again you will bill 1111, 119 and 1101. Okay, so this is, make sure that you are very clear with this one, because I know some coders, they are confused. And even I saw some, like sometimes some facility they are billing 109 also. Okay, some coders are confused with this one. So there is no more 1109. See, nowhere. So it means additional polishing is no more billable. Talking about route planning now, route planning 4 units, okay, in 12 months. So now see here, what is mentioned here, in combination with scaling. So on the right side, I clearly mentioned here that scaling is not covered when route planning is performed. Okay, so again, some coders are confused here that they are billing scaling, polishing plus the route planning. So if route planning is done, it means class scaling is covered already. It is part of this. Okay, so you either scale or bill both. Okay, so make sure that you're familiar with this one. So see, 4 units, mild or moderate. So what is important here? Patient need to have the codes for mild or moderate periodontitis. So when you're billing for route planning, it means you need to have this code for the periodontitis, and not the like only like minor. It should be mild or moderate. Okay, not for the like simple periodontitis. Okay, so make sure that this is also like biannually mean 2 times. Okay, then 4 units for severe and aggressive periodontitis. You can have 4 units plus additional 4. Okay, then the curettage maximum of 4 units covered annually. Okay, so now what is important for you to know that these codes are now only periodontist he can do. Okay, so if you talk about the scope of service, this will you will see this one under the periodontitis, not under the GP. Okay, now another update was about the cyst and cyst and about diagnosis and what the requirement they need. Okay, so Command will require you to provide X-ray when building claim with. Okay, so whenever you have sorry, when you have any case for the cyst excision, okay, so doctor need to document the size of once you remove the cyst, you need to write the size. Okay, and what I suggest also better to take picture also, not only the X-ray but take picture and keep for your proof. In case you will get denials or later on for reconciliation or whenever you have any audits, you need to have a picture. Why? Because for example, doctor has moved very big size, okay, of cyst. So once you have picture, you can simply justify, okay, and plus the X-ray, of course. X-ray is the must, but also take the picture also. Once he remove the cyst, he keep the picture of that case, so that will help you for the future. Okay, so make sure that whenever you are having these cases, cyst removal, you need to have the X-ray. Okay, plus the correct diagnostic coding. Okay, update of dental billing, or did we discuss already? Okay, now my microabrasion before they were paying, now again from 25/12/2023, this is no more payable. Okay, in case some patient they need the microabrasion, yes, you can still do, but you can submit under cash with zero billing. Okay, so make sure that you are no more billing under the insurance. This already discussed also examination 6 months. So what I missed in last slide was that, or yes, when patient is seen with orthodontic, when UB was 01901, and if now this orthodontic, maybe he refer for something to GP or any other doctor, yes, they can bill. Maybe he refer to the prosthodontic to remove some teeth, or he will do any kind of other procedure. Yes, that we can bill for other also within 6 months. But any other examination, you will not be able to bill again. Okay, this is only exception is only for the orthodontics. Okay, so it means if, or another way, if you talk about a patient today is seen with a GP and GP bill for 01205 or 201, and now he referred the orthodontic, and orthodontic he sent the approval 01901. Yes, he can bill within 6 months. Okay, so make sure your concept is clear in this examination. Yes, this slide now time-based code. So I discussed in the previous slide also that you have to know about this one. See, so if you are billing for the 2 units, mostly of course you will bill for the scaling 2 units. So what is important here? If you see the first unit, it is 8 minutes up to 22 minutes. Okay. So now if you are billing for the additional unit for the scaling, so what does that mean? You will write the doctor need to write the time that, for example, patient is seen at 1 o'clock for the scaling. He did the scaling at 1 o'clock. So 1 to 1:15 is 1 unit. Now 15 to 23 or more than 23 minutes, that will be additional unit. Okay. So you cannot put like 8 and 8 minutes because that will be 16 minutes, right? Because some coders they are like confused here now because they think that 1 unit is 8. So additional will be again 8 minutes. Okay. So additional is not 8. Okay. So that will be actually the first unit is 15 and additional is 8 minutes. Okay. So make sure that your doctor is documenting the correct timing if there is the wrong timing you need to query the physician. Dental crown. So again, I discussed before that, before, like every RCT cases, there was crown, but now they restricted. They have a lot of now like updates and about this one crowns. Okay, so what the crown means? Artificial crown replacement that restores missing tooth structure by surrounding the remaining crown tooth structure or is placed on dental implant. Okay, so it can be crown can be on the implant or can be on the natural teeth. Okay, so it is made of metal or ceramic or polymer materials. Okay, so there are different kinds of crown. Okay, so we have the porcelain, cast, full metal, acrylic resin fused with metal. So there are different kind of codes. Okay, so again, you need to make sure that what kind of crown doctor is going to deliver. According to that, you can assign the procedure code. So what is the education policy for that? So all permanent crown code required for authorization. Okay, so all the permanent crown, you need to send the approval for that. Okay, so what is important, like all basic treatment addressing any existing active biological disease caries and must be completed before. Okay, so yes, of course, it is very obvious that when doctor will deliver the crown, of course he will make sure that tooth is treated well. Okay, it's not like that patient has caries and simply the doctor will put the crown. No, of course, I mean the first thing is he will make sure that all his caries or anything else, any periodontal diseases already like treated before delivering the crown. Okay, because what will happen, for example, patient is having any like periodontal disease. Of course, once you will submit for the approval, so that the case manager is sitting there in the other side, in the peer side, they will see the picture. So if the tooth has caries or he has any periodontal disease, they will reject and they will say, okay, first please, they will put some reasons to make sure that tooth is okay for the crown. Eligibility, the amount of considered occur when both the tooth eligibility and restorability criteria have been met. Okay, so tooth eligibility, the amount of considered coverage crown for incisor canine now his teeth with okay. So this one again, like he will make sure that if patient has other side like opposing teeth is also there, then only. So there are different criteria. Make sure that when they reject, make sure that you have justification. You can resubmit if they deny. Okay, multiple crowns per patient. Okay, so here again I mentioned that while multiple dental crowns may be indicated in the certain cases to address extensive damage or decay, it is essential to thoroughly evaluate each tooth clinical need to restoration. So since now in the GPs they can do only like 3 crowns per arch per quadrant. Okay, now any special case more than 6 crowns, they need to refer it to like specialists or prosthodontic, or then they will evaluate and then they will see why patient needs more crowns or maybe they need different treatment, like full arch or those things. So GP need to refer those cases to a specialist. So longevity, dental crowns are expected to have minimum lifespan of 6 years. Okay, so it means that if patient will bring that crown broken within 6 months, and again you will send approval, okay, the insurance company, they will not approve again within six years. So make sure that of course doctor, they are giving instructions to the patient to not to eat hard food and all these instructions. So if any case within 6 years, either patient will pay or it's not the provider, but insurance they will not approve within six years. The age threshold is 16 years. Okay, so only if you have the patient like above 16 years, then they will approve this one. Provisional crowns already we discussed. Okay, tier side is again tier side temporary crowns should not be reimbursed. If you talk about the re-cementation or repair of crown, okay, now this is once per 3 years. Okay, so it means patient is coming with sometime the patient has crown, maybe he's coming after 1-2 years, he has loose crown, so doctor will re-cement. So you can do only once in 36 months. Okay, so what was mentioned here in the 60 years, okay, the longevity, and resummation is 3 years. So it means that only once per 3 years they can do the repair or resummation for the crown. They can bill it. You know those codes, right? 29, I think 29301 or 101. Those codes are for resummation. So you can bill only once per 3 years. Okay. So what are the requirements for the authorization to send the approval? You need to have the X-rays, not more like older than 6 months. Okay. Yes, of course. Sometimes they will ask for the OPG and also the digital photographs. Okay. So why they will ask for photograph again to make sure that the tooth is okay for that crown and it doesn't require any other further treatment. Okay. So non-coverage for the basic plans it is not covered. Okay. Why not cover crown once more than following? So this already we discussed already. Yeah, if you see this one, sometimes the use and approval for patient has like spacing in the teeth or discoloration or the pec teeth. So yes, that is for the aesthetic use. Okay, just to make sure that your smile is good. So yeah, of course, yeah, those cases they not approve because this is for the aesthetic use. Tender crowns, yes. Now if you read here, so this is also very important for coders to know. Okay, the preparation, diagnostic, wax up, electrosurgery, temporary restoration. So see temporary restoration before you are willing that one, right? And impression, laboratory phase, soft tissue recontouring. So this one again, see this one, soft tissue recontouring. So before what was happening that because there is patient has like enlarged gum or they have they need to recontour that area for the crown to prepare for the crown. They were doing gingivectomies and soft recontouring. So this is now no more billable. Okay, so this is included in that crown. Okay, so make sure that if the doctor they are removing that comes to just fit the crown, it will not be billable. Okay, if you initially bill it, if you get the payment later on, it will go for recoveries. So these are like crowns codes. Okay. So mostly if you see this one 27201, of course most of you are familiar with this one. This is endo crown. Okay. So these are all codes for crown. So this is a list of crown where this all this circular about. Okay. So endodontic education we'll talk about endodontic. Okay. Just give me 1 minute, please. Okay, so let's talk about now endodontics. So again, now since you know that before, like you can bill for the multiple codes when doctor he was doing the RCT. For example, the like reinsertion medication, re-RCT, okay, pulpotomies, lot of codes we are billing for. But now with this new like education guideline, okay, we are limited to only the few. We can bill only few codes. Even doctors doing the procedure, yes, he can document or you can bill with the zero billing, but we cannot reimburse those. Okay, so what this guideline means, okay, the man will consider coverage of fluid hazards, canines, okay, so all this. To disability, the man will consider a cover of the root canal treatment when all following criteria met. Okay, so this they need to have patient need to have the decayed periodontal support. Okay, then based on alveolar bone level crown ratio of at least this one, okay, 1 by 1 with the absence of percussion involvement. Okay, decay remaining non-disease tooth structure. So these are all requirements they need to have when they are doing the endo treatment. So for RCT, they doesn't require the approval like a product resolution for the TICA, but of course for the enhanced, yes, it need the approval. Okay. So pulp vitality test are considered integral to the endodontic. So this is not payable like with the endodontic treatment. Root canal or endodontic treatment is not appropriate in the absence of pulp disease. So if patient has any pulp disease, it means that time they will not like cannot do the RCT treatment. In case of extensive case involving the percussion, extensive bone loss due to periodontal disease, percussion defect involvement with the extensive bone loss, and internal and external absorption and with questionable and unfavorable prognosis. Okay, so again, these all things. Again, this is like, of course, as a code, you will just sign the code, but doctor he need to know this all this guideline when he will do the RC treatment. Multiple root canal treatment in the anterior region, intended to justify for crown for cosmetic reasons will not be reimbursable and subject to payment recovery. Okay, see multiple root canal treatment in the anterior region. So see anterior tooth, the RCT intended to justify for the crown. So see sometimes for the crown delivery for anterior teeth, they are doing the RCT. So this will be again, if even they are paying it, it will go for the payment recovery. Okay, anterior teeth that has root canal therapy alone does not qualify for indirect assessment. So this is actually, I mean, we have less time, so I will not go all this. So later on, I'll share with you this presentation, and you need to do all this. Okay, I will talk about the temporary situation. Okay, so now before they are paying for that code, 20111, that is for the pain relief and for the temporary. Now again, it is not no more payable. Okay, they're included. See. Temporary restorations, relative dressing are included in the payment of pulpectomy, pulpotomy, okay, and root canal treatment. Open and drain pulpectomy, reinsertion of endogenic material, obturation or apexified canals code is not to be billed when endo are done on same date of service. So see, so this is very again important before you are billing open and drain. And if you talk about the again about the clinically also, of course, when there is open drain, you cannot do the RCT because you will open the canal and you will keep it for to dry, and then only after a few days you can do the RCT. Okay, so on the same day when there is open drain pulpectomy or reinsertion, you cannot bill for RCT. Temporary restoration is not reimbursable with direct pulp capping. See this one also. So before you are billing direct pulp capping with this one. So now it's not reimbursable. So what it is include also local anesthesia pulpectomy. So now again, see now, if doctor is doing the RCT, okay, local anesthesia of course before not billing, but pulpectomy, okay, then the chemotherapeutic treatment and obturation. Okay, so these all are included again. Okay, so coverage and frequency guideline. Once the root canal treatment is completed, either core on medical necessity or final restoration can be built. Okay, so what does mean? So after the RCT, they are doing the final restoration or they are putting the core build up. Okay, so once the tooth treatment is completed, after treatment only they can bill. Okay, so what does it mean? Is meaning once they complete the treatment, then they can bill it. Okay, the final restoration or the core build up. The final fee of root canal treatment include the cost with the pulpotomy, and open and drain within the 3 months period prior to completing the root canal treatment when performed by the same. Okay, so this is very important now. So if you read carefully, what does it mean? The final fee for root canal treatment includes the cost with the pulpectomy. Okay, so it means the root canal treatment. Okay, when doctor is doing the pulpectomy, pulpotomy, open and drain within the 3-month period prior to the completion of root canal treatment. Okay, so it means like 3 months before, if the patient has having this open and drain and this pulpotomy, pulpectomy, then okay, but within that time period they can split separately. Retreatment. Okay, now this one retreatment. The first thing I want to talk about retreatment is now before GP can do the retreatment, but now only endodontic or specialist say only he can do the retreatment. Retreatment of the root canal therapy by same dentist or group practice within 24 months is considered part of original procedure. So it means that if RCT was done within last 2 years, okay, you cannot bill again. If it is more than 2 years, yes, retreatment must be carried out by specialist. Okay, so within 2 years, if retreatment on the same teeth, you cannot bill it. Even if you're getting payment and you will get payment, it will go for payment recovery. Okay, so make sure that within 2 years, no more re-RCT. Okay, palliative treatment also is not allowed. Okay, when you're doing this treatments, palliative is for the pain, right? So it is, you cannot bill it. Okay, so and I'll share with you this one. This was the like most updates. Okay, so let's go for next. Okay, now talking about the dentures and onlays. Okay, so dentures are discussed in that slide in the prosthodontic. Okay, so what is the now new education guidelines for that one? Let's go to the guideline itself here. Okay, so let's discuss about what is the like bridge. Okay, denture or bridge. Okay, so see bridge we have on different kind of like a bridge. We have traditional bridge, Maryland, blunt spotted, okay, or cantilever. Okay, so as a coder again you have to be familiar with this bridges. Okay, and the code, because we have different codes for each of this bridge. Okay, all fixed bridge require authorization unless mentioned otherwise in the related schedule of benefits. Okay, so this list, I think all of coders you are having this list where, you know, as I mentioned that it which code is procedure like approval and which doesn't require. So if not, let me know, I will share with you later on. Dental implants spotted bridge are outside the scope of guideline. All basic treatment, dressing an existing biological disease, caries, environmental disease must be completed. So this is same like, you know, like before RC, like same like RCT. So before delivering the bridge or crown or implant, doctor need to make sure that, you know, all like, you know, basic treatments are completed for that tooth. Fixed bridge procedure must number under 16 years of age are not covered. Okay, so if patient age is less than 16 years, it is not covered unless there is, you know, like any medical necessity or any, you know, special cases, then only the manual approved. Redo of fixed procedures for same tooth across all providers is covered only if the existing procedure was inserted 6 years. Okay, so within 6 years, again, it is not payable. After 6 years only, you can send approval and it will be reimbursed. So same is for the fixed partial denture, also same thing, 6 years. Okay, so same for the all the bridges. Okay, so this is actually same. I will again share with you. This is a long this one definition. So this is more about the doctors. They have to know that, you know, when to deliver the bridge and all these things. Okay, onlays. Again, this is like I think some coders they are familiar with what is onlay and difference between onlay and the crowns. So if you this is the picture is very clear, you will know. Okay, what is crown, what is onlay, what is inlay. So inlay is no more like payable. So they are only even now they are paying for the onlay and the crown. So crown is the basically, you know, when they cover the see the top all area, this is like crown fitted. Okay, onlay is only like, you know, layer on the top of the, you know, when patient have the caries in the they lost the tooth structure on the top of the, especially in the molars, then they are delivering the onlays. Okay, so if you see here also this in this picture, so crown is on the all over the like or the tooth. Okay, onlays only in the top area, and inlays and the very like little area only, minor only. Okay, so you need to know this what is the difference between crown, inlay and onlay. So let's talk about coverage only. To improve aesthetic, non-coverage. Okay, non-coverage. So for aesthetic use, of course, they will not pay if lesser mean to restoration acceptable for high risk caries Okay, so this is non-coverage. Okay, so only if patient is really like there is medical necessity, only then they will approve for the onlays. The coverage of member 12 year of age or old. So this is 16 years crowns, but onlays is 12 years. Okay, this is the difference. And as you can see, once per tooth in 6 years across all providers. Okay, and this is same for the crown and only same 6 years. So for the approval, of course, same thing. They need the picture radiographs or PGs sometime when you send the approval only. Okay, talking about the surgical curettage. So again, this procedure again only the periodontist he can do this procedure only. Okay, so surgical curettage to include definitive root planning per sextant will cover solely when requested by specialist periodontist. Okay, so GP cannot do this procedure, only specialists can do. Additionally, the services covered maximum up to 4 quantities annually. Okay, 4 quantities. Since this code is sextant based, see this one, sextant base code. So you can bill 4 annually. Okay, so again, they did not mention here, like the 4 you can bill together or like after 6 months, or it depends, like when our patient is, you can bill for the 4 sextant. This one we discussed already. Okay, about the scaling. So below 6 year and polishing. Okay, so this we discussed already. Okay, so that's all from my side. Thank you so much. Okay, so if you have any questions, please go ahead. Thank you guys. Thank you so much for joining. So if you have any questions, either you can type or you can just unmute your mic and you can go ahead, please.
Thank you, Basharart. Thank you for your wonderful session today. I hope all our members would have benefited already. Not will be, would have benefited already. Okay. Before going into the Q&A, I will share my screen where we can. On behalf of all our members, I would like to share this certificate with you, so that after that we can go to the Q&A session. Okay. I hope you can see my screen. So, as a token of thanks from all our members, I would like to share this certificate with you. Thank you, Bashar. Thanks for your wonderful session again. And yes, Bashar, we will be sharing with you after this session actually. So I will be turning on the mic for all our members so that they can ask their questions if they have any. One second.